Hello students, welcome to today's session on nutritional requirement in geriatrics. In India, the older people contribute to 7% of the population and which is expected to rise by 177 million in the year 2025. Due to several physiological and psychological changes that happens during old age, the requirements in terms of food and nutrients is also higher. Hence, the requirement should be met through a proper, well-balanced meal, so that the changes which is due to psychological as well as physiological could be maintained and to have a happy aging process. Each older adult has unique needs, so dietary recommendations should be individualized. The current dietary reference intakes established to optimize the health for individuals and groups provide a guideline for assessing intake and estimating needs and reflect the latest understanding about nutrient requirements. Let's move on to the energy requirement. Energy requirement generally decrease with age because of changes in body composition, a decrease in the basal metabolic rate, and a reduction in the physical activity. An estimation of energy needs can be determined based on the actual or a desired body weight, basal energy expenditure, resting energy expenditure, or total energy expenditure. The percentage of muscle tissue decreases and fat tissue increases as the age increases. Resting metabolic rate decreases up to 15 to 20% over the lifespan. Lean body mass declines approximately 2 to 3% per decade. Body protein level in the healthy elderly is 30 to 40% less than that in younger adults. The average body fat percentage in male increases from about 15% when young to 25%. This is due to less intense physical activity and alteration in testosterone and growth hormone production that affects the anabolism of lean tissue growth. Meeting the nutritional requirements of the older adult can be challenging because although the energy requirements decrease, most requirements for protein, vitamins and minerals remains the same or increase. Although obesity in humans is associated with a shorter life expectancy, the extent of the effect is somewhat controversial. Some data have indicated that the mortality rate associated with underweight is the same as the rate associated with moderate obesity, particularly in those older than 60 years of age. A desirable BMI can be estimated in relation to a person's age to determine a more appropriate estimate of energy needs. Health problems arise when intakes are less than 1500 kilocalories per day. Supplementation is often needed for those who have a severely restricted calorie intake. Here is the energy requirements for Indian elderly people in different body weights. Moving on to protein requirement, as people age and experience loss of skeletal tissue mass, stores of protein in skeletal muscle may be inadequate to meet the needs for protein synthesis, making dietary protein intake more important. Decreased food intake, a sedentary lifestyle, and reduced energy expenditure in older adults become critical risk factors for malnutrition and especially for insufficient intake of protein and micronutrients. Although the recommended intake for protein has not changed, some studies have demonstrated that an intake of 1 gram per kg is needed to maintain positive nitrogen balance in an older adult. A protein intake of 1 to 1.25 gram per kg is generally safe for older adults. Protein needs increase in relation to acute and chronic diseases. Stressful physical and physiological stimuli can induce a negative nitrogen balance, infection, altered GI function, and metabolic changes caused by chronic disease can reduce the efficiency of dietary nutrition use and increase nitrogen excretion. The serum albumin level is the most reliable indicator of protein status in older adults, whereas other short-lived proteins such as prealbumin and retinal binding protein may be used in more serious situations to evaluate a person's response to therapy. Healthy ambulatory older adults can have serum albumin levels greater than 4 grams per dl or 3.5 grams per deciliter because of fluid shifts when lying down for long periods. Other serum protein values such as transferrin, urea nitrogen, and total protein are less reliable but may help evaluate an individual's response to therapy. Serum albumin levels can be used to estimate protein needs. Here are the requirements of protein for repletion of low serum albumin levels. Since calorie requirements are decreased with no corresponding decrease in protein, the food should be protein rich compared to normal adult diet. To meet these requirements, adequate amount of protein foods such as milk and curd can be included. Due to decreased appetite and poor digestion, old people are likely to consume less protein. Deficiency of protein leads to edema, anemia, and lower resistance to infection. Of the total calorie intake, 11 to 12% should be from protein. Moving on to carbohydrates, an impaired glucose tolerance in the elderly can lead to hypoglycemia, hyperglycemia, and type 2 diabetes mellitus. Insulin sensitivity can be enhanced by balanced energy intake, weight management, and regular physical activity. Emphasis is placed on complex carbohydrates and controlling the intake of simple sugars. Whole grain cereals and pulses should be included in the diet. Abundant carbohydrates are needed to protect protein from being used as an energy source. Current dietary guidelines recommend that approximately 45 to 65% of the total daily calories come from carbohydrates. Emphasis should be placed on increasing the intake of complex carbohydrate sources such as legumes, vegetables, whole grains, and fruits to provide fiber, phytochemicals, and essential vitamins and minerals. Moving on to lipids, the current adult dietary guidelines recommend that no more than 25% to 35% of total calorie intake comes from lipid. Emphasis should be placed on reducing the intake of saturated fat and choosing MUFA or PUFA fat sources. Although limited evidence shows that dietary changes can reduce the risk of cardiovascular events in older adults, people have no reason to doubt the same environmental factors leading to a decreased risk in younger population will continue to be effective in later years. The recommended modified use of dietary fat also supports principles of weight control and cancer prevention. Conversely, restricting dietary fat to less than 20% of the calorie intake may affect the overall quantity of the diet and negatively affect taste, satiety, and intake. Elders who take sufficient omega-3 fatty acids have better visual acuity, and it may help in conditions such as hair loss, impairment of vision, improper digestion and poor kidney functions, tissue inflammation, osteoarthritis, painful joints and muscles, and mental depression as well. Moving on to the minerals, aging produces physiological changes that affect the need for several essential nutrients, whereas mineral deficiencies are less common in the healthy adult. Subclinical nutrient deficiencies that affect metabolic function can also develop. Poor mineral status in the older adult can be attributed to the inadequate dietary intake, physiological changes that affect the need for a nutrient, and medications. Some older adults may have to increase the variety of their diet and take a non-food dietary nutrient supplement to consume adequate level of nutrients. Diminished lactase secretion can cause lactose intolerance and GI compliance, which can result in decreased consumption of dairy products. Dietary modifications, including controlled intake of lactose containing products, substitution of less problematic dairy products, and use of lactase treated products, can help alleviate the discomfort from cramping, flatulence, and diarrhea. Moving on to calcium, people age, they experience an intrinsic decrease in calcium absorption, primarily because of a change in calcium support. As the calcium decreases below its necessary level, calcium is mobilized from the bones to maintain the calcium concentration of extracellular fluid, destroying the whole bone. Bone loss resulting in osteoporosis, the presence of hypochloria, and failure to efficiently absorb calcium can affect calcium status. Women over 50 years of age who are not receiving estrogens require more calcium, as there is increased losses resulting in demineralization of bones. Hence, to avoid fractures and dental decay, 1000 milligrams per day of calcium is recommended. Milk is an important source of calcium for elderly, as it is in the diet of the young. Wise provisions for calcium throughout life may go far in assuring an above average measure of health, an increase in vitality, and perhaps in the lengthened prime of life. Hence, calcium supplements are essential. Moving on to the iron deficiency anemia is uncommon in older adults than in the younger adults, especially in women after menopause. In older adults, anemia is most likely to be related to blood loss from disease and medications, or decreased absorption caused by medications or hypochlorhydria, reduced non-heme iron absorption secondary to achlorohydria, of atrophic gastritis. It affects the health of old people due to less efficient circulation of blood. Iron absorption does not appear to decline significantly with age. Vitamin C deficiency may also impair iron deficiency. Vitamin C deficiency may also impair iron absorption. The iron intake should be adequate to prevent anemia. Iron requirement can be same as adult men with 30 mg per day. If there is anemia, supplemental iron can be given. Consumption of liver once or twice a week is effective in combating such a tendency. Particular emphasis may be placed upon the inclusion of green leafy vegetables, which are good sources of iron, like mayaluk, cauliflower greens, and agathi, and whole grains or enriched breads, and certain iron-rich dry fruits, and use of iron fortified salt. Moving on to the zinc, intake of zinc in older adults decrease in relation to the decrease in energy intake and are much lower than the recommended level of 15 mg for men and 12 mg per day for women. Definite indicators of zinc status are not available, which impedes its assessment in older adults. Older people who avoid eating meat and fish may be at increased risk of poor zinc status because reduced bioavailability of zinc from other food sources. Zinc deficiency is associated with impaired immune function, anorexia, dysgeusia, delayed wound healing, and pressure ulcers. Moving on to sodium, sodium intake is often associated with hypertension, but it is difficult to identify individuals who are sensitive to dietary sodium. Therefore, it is prudent to limit the dietary sodium intake to approximately 2 to 4 gram per day and increase intake of other minerals such as potassium, magnesium, and calcium. There is no evidence that moderate sodium restriction will delay or prevent the onset of cardiovascular disease. It is believed that great restriction of sodium should not be attempted except under the advice of a physician in the treatment of specific disease condition. In fact, moderate amount of salt help to improve the palatability and thus the acceptability to the diet as well. Moving on to vitamins, oxidative mechanisms may play an important role in the aging process. It is important to emphasize the relationship between health and nutrition, particularly in relation to requirements for antioxidant vitamins such as tocopherols, carotenoids, and vitamin C. Antioxidant acts as a buffer against cell damage that can occur during normal cell function. If this cell damage is allowed to accumulate, the risk of certain disease such as cataract, heart disease and cancer increases. Suboptimal intakes of key vitamins may place a person at risk for chronic illness, especially in the elderly. Moving on to vitamin A, the assessment of vitamin A intake are important because it is often deficient in diets of older adults. However, the consumption of too much of vitamin A is not beneficial, as high dose may contribute to the incidence of hip fractures. The dietary sources of vitamin A, such as dark leafy, green leafy vegetables, yellow orange fruits and vegetables, should be carefully included in the diet to provide adequate but not excessive beta carotene, the precursors of vitamin A. Moving on to vitamin C, older adults often have lower serum levels of vitamin C than younger adults. However, no age-related alteration seem to be associated with the absorption or use of vitamin C. Stress, smoking and some medications can increase vitamin C requirements. So, an assessment of dietary intake is especially important for individuals who may at risk. Encouraging the consumption of vitamin C rich foods may be the most effective way of improving vitamin C status in the older adults. Vitamin C may be protective of cataract at an intake level of between 150 and 250 mg per day, which is possible to achieve from dietary sources alone. Moving on to vitamin D, the requirement of vitamin D depends on the concentration of calcium and phosphorus in the diet and the person's age, sex, degree of exposure to sunlight and amount of skin pigmentation. The ability to synthesize vitamin D from the sun is approximately 60% lower in adults. The influence of age on vitamin D absorption from the GI tract is unclear. The lower levels of vitamin D in older adults who are institutionalized or homebound may result from decreased exposure to sunlight, less efficient synthesis of vitamin D in the skin, or a decrease in renal mass that causes insufficient production of vitamin D. A decrease in skin thickness is partially related to the lower level of 25-hydroxy D levels that are associated with aging. Vitamin D may help heal skin lesions, especially those caused by psoriasis, hyperproliferative disorders of cancer and keratosis. Moderate dietary supplementation with calcium and vitamin D improves bone density and may prevent fractures in healthy older adults. Moving on to vitamin E. It may be beneficial to enhance the vitamin E content in diets for older adults. From epidemiological studies, the antioxidant properties of vitamin E may help reduce the risk of cardiovascular disease, in part by reducing the susceptibility of low-density lipoproteins to oxidation, thus decreasing the vascular endothelial cell expression of pro-inflammatory cytokines. Changes in immune system can be overcome by taking 200 mg of vitamin E. Protection from DNA damage enhances the body's self-defense mechanisms. Moving on to vitamin B6, many studies have demonstrated that older adults do not consume enough vitamin B6 because of atrophic gastritis, alcoholism and liver dysfunction. Requirements for the vitamin are increased in some older adults. Let's see the folic acid. No specific age-related impact on folic acid requirements are known. However, alcoholism could result in a folate deficiency. Severe deficiencies in an older adult may result in anemia and risk for cardiac disease. Diets are often lacking in folate, so consumption of folate fortified foods or folate rich foods should be encouraged. Moving on to vitamin B12. Screening of vitamin B12 levels in older adults is needed because of the prevalence of deficiency related to gastrointestinal and metabolic changes. Vitamin B12 deficiencies affects 10 to 15% of those older than the age of 60. The usual cause of vitamin B12 deficiency are atrophic gastritis, bacterial overgrowth, pernicious anemia and decreased absorption related to conditions such as Crohn's disease, ileal resections or malabsorption syndrome. People with these conditions may require a higher dietary vitamin B12 intake and need oral or injectable vitamin supplementation. Vitamin B12 is important for all older adults, not just those with deficiencies alone. Let's move on to water. Hydration status is a critical component of the initial and ongoing assessment of a person at any age. Fluid needs are affected by variations in activity, insensible water losses, medications, and urinary soluble load. Daily fluid replacement is essential, particularly in those who exercise regularly, consume large amounts of protein, use laxatives or diuretics, or live in areas with high temperatures. In general, daily fluid needs are approximately 30 to 35 ml per kilogram of actual body weight, with a minimum of 1500 ml per day or 1 to 1.5 ml per kilocalories consumed. With age, the total body water decreases. Water accounts for approximately 50% of an older person's weight, which is 10% less in younger adults. The decrease is associated with the corresponding decrease in lean body mass. Reduced thirst sensation, reduced fluid intake, limited access to fluid, diminished renal function, and urinary incontinence all increases the risk for dehydration. Dehydration is more common in older adults than recognized. Symptoms of dehydration include electrolyte imbalance disturbances, altered drug effects, headache, constipation, thirst, loss of skin elasticity, weight loss, cognitive status deterioration, dizziness, dry mouth and nose mucous membranes, a swollen or dry tongue, blood pressure changes, recessed or sunken eyes, changes in urine color or output, and speech difficulties as well. An insufficient fluid intake in a person with frequent diarrhea or vomiting, fever, illness, infection, organ failure, or some chronic disease can lead to clinical dehydration requiring hospitalization. Careful monitoring of the fluid intake and output is important. Water can be consumed as such or in the form of buttermilk, fruit juices, porridge and soups. Moving on to fiber. Fiber stimulates peristalsis. There is great enthusiasm to encourage the consumption of fiber containing food, but any increase should be gradual, otherwise bowel discomfort, distension and flatulence will result. While rough fiber, bran and mature vegetables are not advised for the age, the fiber of tender vegetables, fruits will make easier the passage of food mass down the intestinal tract. Fiber also helps in reducing cholesterol, which may reduce the incidence of atherosclerosis. Excess fiber may reduce the absorption of iron and certain trace elements. Diseases like diabetes, atherosclerosis, hypertension, cataract formation, Parkinson's disease and cancer, and disability disorders like bone fractures, arthritis and strokes may affect the nutrient requirements, intake, digestion, absorption, metabolism and excretion. So to conclude, we have seen the psychological changes as well as physiological changes that happen in geriatrics, which includes the physiological changes with body composition, renal function, gastrointestinal function, immunocompetence and the other function, along with the psychological changes such as anxiety, depression and other phenomena has to be balanced. So this could be counteracted with the sufficient input of the nutritional diet with proper food and nutrient intake. So the intake, though the energy levels are much less required when compared to other age groups, the requirement of protein, calcium and vitamins are more during the old age. Hence that must be adequately met through proper amount of protein foods, calcium rich foods and lot of fruits and vegetables. And there is increased requirement for water and dietary fiber as well. This also could be met through lot of fruits and vegetable usage and the intake of fluid. So the dietary fiber is very much important for the laxative purpose, and hydration is also very much required during old age. So along with the requirement of protein, calcium and the vitamins, more amount of water and the dietary fiber must be included in the diet to balance the requirements among the old people.